Why do I just think it's about brain disease and decline and loss? Why can't I think, how can I reimagine the experience of dementia differently? And at that time, I was also meeting people who were living with dementia, who are the best stigma busters in the world, because you talk to people about their lives, how they feel, and you realize that it's a much bigger world than you ever imagined. And even I, who had cared for people with dementia, am ashamed to say I wasn't paying enough attention to what they were teaching me in the early days. And when I learned from people who were more able, who were speaking at the WHO or giving lectures and conferences and writing books, I then began to look at everybody with dementia as a potential teacher who's instructing me about what they need to live well and what I can do to help us all to live better.
Hey y'all, this is Kosta, and today I'm here with my guest, Dr. Al Power, board-certified internist and geriatrician, educator, and published author. Internationally recognized for his work challenging the use of antipsychotic medications for people living with dementia, Dr. Power's focus is bringing knowledge into practice to transform the culture of care, from philosophical to system shifts to physical design concepts for community living. Today, we're talking about the power of purpose and how to empower those with dementia. So, Dr. Powers, thank you so much for joining us today. Would you start by sharing a bit about your background and what led you to focus on dementia care and aging?
So my life's been a series of accidental moves, I guess. But I love the introduction you gave. I think if you asked me to describe what I do, I probably couldn't have come up with some better wording than what you said. So I appreciate that. I started as an internist in private practice, thinking I'd be a GP all my life. And after 7 years of a very busy, sometimes overwhelmingly busy practice, I saw an ad to work as part of a medical staff in a large long-term care home. I never would have thought of it before, but I investigated it. It seemed like it might be interesting. And so I made the move and got interested in geriatrics, became a geriatrician. And then somewhere along the line discovered some of the movements to transform nursing homes. And we'll talk about those later. I know movements like the Eden Alternative and the Pioneer Network Greenhouse Project, and became interested in looking at what I did differently. And all along the while was not particularly happy with the way we cared for people with the diagnosis of dementia. As you know, they're very prevalent in nursing homes. Some people say at least 2/3 of people living in nursing homes have some form of dementia, and it may even be higher than that. And never particularly liked the use of antipsychotic or other psychiatric drugs. It seemed like they never really solved any problems. They just quieted people or maybe caused side effects. But I never really had a great way of explaining what to do differently. And so I spent a lot of time struggling with that. It was finally in my second long-term care job, about 2000, 2007, 2008, that I really realized that I had to put down what I was thinking and figure it out. And that's when I started working on my first book, which came out in 2010, called Dementia Beyond Drugs. And it was about a year after that the media became more focused on antipsychotic use in dementia, and the government began challenging nursing homes to reduce their use of the medicines. And by then I'd written the book and I developed a course for the Eden Alternative and done a lot of lecturing around the country, and all of a sudden I got popular. And so that just launched another career. And I left the daily practice of medicine and have just been doing education and consulting for over a decade.
I can't imagine what it must be like to be a medical professional, a doctor, in the long-term care space. I mean, it must be maddening at times because, it's so chaotic to begin with. And you have this, this very kind of professional background, and you're working with so many people who can't quite have a very difficult time of understanding the medical side when it comes to long-term care.
Yeah, it's maybe an advantage I had is that I worked sequentially in two different homes, and they were both very large, so that they had a full-time medical staff. So being part of a full-time medical staff, unlike most doctors who stop in a couple times a month and see a few people, I was there. My office was there. I knew all the workers. I went to all the meetings. So I was really part of the culture and sort of the community of the nursing homes. And I think that did help me to understand it better. I worked with some amazing people. I understood that there were a lot of good people often working in a broken system, and that systems change was going to be equally important to education.
Yeah. So you're a passionate advocate for person-centered care in dementia. Two questions. What is person-centered care? And why is this concept such a powerful tool for individuals living with dementia and their caregivers?
Person-centered care is one of those terms that has been thrown around for about 30 years now, ever since I think it's credited to Professor Tom Kipler, who wrote a seminal book on dementia back in the 1990s. And I've gone through many evolutions. Some people say person-directed care, some people say relationship-centered care. And I think that all of them can be good or bad depending on how you really see them. So the words don't mean as much as the way you practice them. And in my way, when I think about these different terms and their relative strengths, maybe the one that bothers me the most is the word care, actually, because we often equate care with just treating people. And that's what happens particularly in nursing homes, but even at home when people have dementia, it becomes a treatment process. And we forget about living. And so a lot of it is helping people to live along the lines of the way they want to live their lives as well as possible. There's a group that came from Dr. Sherry Dupuy up in Waterloo, Ontario, and they came up with the term authentic partnerships. And I kind of like that term.
Okay.
Because it's an authentic relationship and it's a partnership. You're not doing to somebody or doing for somebody, but actually doing with somebody. And that really forces us to look at each individual, to use high levels of empathy, to understand who they are, what they're feeling, what they want, and to do our best to partner with them to help accommodate their disability, to help them live as well as possible in spite of the dementia.
And so you've been working in this long-term care space for a very long time, and you're kind of now, even though you're still a part of the community, in some aspects, I think it's almost outside looking in you have a different vantage point, which is important. As you're looking at the industry from your perspective, given all that you know and all that you've experienced, do you feel like we are improving in terms of identifying people to provide services to individuals with dementia? Do you feel like we are improving in the capacity of finding more people with empathy or less? Because I think when you said empathy, that's a very important word that is missing in my interactions with a lot of different facets of our industry.
Yeah, Kosta, a lot of the answer to that question for me depends on the day, maybe it depends on the minute, how I'm feeling about the state of long-term care. Sometimes you see some amazing things going on and you feel like, there's hope. And other times you just see sort of the institutional effects, and what people refer to as the dragon at work, kind of pulling you back into institutional thinking, and so it's hard to say. I do think that we slowly move the needle, but I think we have a long way to go. As far as the kind of care staff, I think once again we try to do our best, but there are some barriers to having all the best people we can. The biggest barrier in recent years, of course, has been the pandemic. I think it's been estimated that we are down at least 200,000 workers just to fill slots, let alone having people with the empathy, with the skills, with the compassion, et cetera. And unfortunately, because the job is so demanding and because the pay and benefits in this country and in many countries are so relatively poor, it is hard to attract people that have those special characteristics.
Yeah.
Because there are many other jobs that are less demanding that pay more than that.
Right. And long-term care is a space that you really do have to innovate to make an impact. And so on that note, as a trained musician, you've incorporated music into your work with those living with dementia. What impact does music have on people with dementia and their overall well-being?
I think music can have an incredibly important impact. It has to be used intentionally. I think that sometimes just putting on music in the dining room doesn't necessarily have a positive effect. It may actually bother some people that don't want music in the dining room. But certainly what we found, particularly with the Music and Memory project, which you've mentioned in the past, is that when you create music that is personalized, that speaks to a person's history, their likes, their relationships, their memories, then it can be extremely enabling and energizing to share that music with people. It can reawaken memories and other abilities that may not be easily accessed at other times. That reawakening can last even for hours after the music is enjoyed. And so it's really a way to engage all the parts of the brain to help the parts that are maybe not working as well as they did before. And it stimulates emotions, stimulates memory, stimulates all kinds of very important aspects, of your life to connect to those kinds of music. It can also be used intentionally by music therapists in a therapeutic way to help with movement, to help with other types of things in daily life. Rehab, for example, is a project going on right now at the U of R with the Eastman School of Music here, where they're using music to help people get over fear and difficulties with rehabilitative training and finding very good results.
So I'm always fascinated by technology and how it incorporates into the long-term care space. What role do you think technology can play in enhancing the quality of life for people with dementia, and how can caregivers effectively utilize these tools?
It's technology is such a tricky thing, and I think that there's a lot of potential there. I think there are also some cautions. One of the cautions is that technology really should be developed in partnership with the people who live in long-term care or older people in general, if you're talking about smart homes or whatever. I think too often we have the technology wonks who are designing things they think would be great, but they don't actually ask the end user what's user-friendly, what they need.
Right.
One of the things I see that's a great direction is the so-called zero-effort technology that really requires the least amount of knowledge and specific effort on the part of the person in order to be supported by the technology. I think that's great. I still, in my mind, the jury is still out on the use of things like robotics and those things.
Okay.
They certainly have gotten very far with AI, but I'm concerned that the kind of observation and empathic skills that I think a really good care partner needs to understand the symbolism behind what people with dementia say, the metaphors, the maybe unspoken needs. I'm really having trouble finding out how that can be done in a technological format. So I often go with the mantra that Bill Thomas used to use, the Eden founder. He used to say technology for tasks and people for relationships. And I've still kind of held that dichotomy in my head when I think about it.
Well, and so one of the things that we're doing within our organization is we're trying to roll out a remote support system to try and facilitate an increase in services, because it's very difficult to find qualified caregivers that are willing to perform this type of work and do a good job. And through this remote support service, I do find that it is very difficult to thread the needle with individuals who are receiving care services, and they would prefer to have a human being as opposed to a camera or a sensor or some type of electronic device. And I've heard a lot of people say that, we should be investing in the workforce as opposed to investing in alternatives to the workforce, right? But what happens, and I'm just curious to get your take on this, what happens if there's just not enough people that want to work within this industry? What do we do then? Do we make the industry better or what?
let me take you out in the left field for a bit, because you're speaking directly to a point that I've been making with a lot of healthcare planners and discussants for quite a while. Many years ago, when I was researching my second book, I read about a statistic that I had not known about that really is kind of the bottom line. And it's not anybody's opinion, it's pure mathematics. And that is, it's called the potential support ratio. And that's roughly how many working adults there are in society for every retired adult. And they just use it by a very crude age cutoff. But in 1950, that was 12-1, 12 working adults for every person who was retired. In 2000, that dropped to 9-1, and it's predicted in 2050 that might be 4-1. So the larger question, I think, is that we cannot continue to build separate living areas for older people. Because we won't have the people to staff them. Machines are not.
Right.
I think the thing that we are missing in our political and our policy discussions is how can we shift our focus from making people do on their own or with their family members till they can't, and then move to a senior living campus, versus creating inclusive, empowering communities that demarginalize and empower and integrate older people into communities that don't just rely on blood relatives to provide all your support, or a lot of financial resources to bring help into the house. Taken in the larger sense, community-based care is a lot cheaper and more efficient than long-term care, even though we
Agreed.
put all our money in long-term care. And there will always be a need for
Right.
congregate living. I'm not saying that congregate living will go away, but we cannot respond to the aging boom that's coming over the next couple of decades by building that many more long-term care beds, because there will be nobody to work in the building. And so it really begs a larger question. Yeah, we can make nursing homes better, but nursing homes cannot be our primary solution anymore to people who want to age and become either physically or cognitively frail. Interesting thing I've discovered in all my years is that when it comes to whether you're living at home or living in a nursing home, really your age doesn't matter, your physical illness doesn't matter, your cognitive illness doesn't matter. I've seen people at home who are every bit as needy as people in nursing homes. The difference is what kind of support do you have in the community? And that's the only difference, really, that says you can live here, you can't live here. And it seems like we could marshal a lot of financial, social capital, housing changes, accessible, walkable communities, do a lot of things from many angles to create a much better place for people to age so they don't have to go as soon to a place like a nursing home.
And I know that we're maybe going into a bit of a rabbit hole, but lucky for you, I have tons of time this afternoon.
Rabbit holes are, when you do this kind of work, you live in rabbit holes, basically.
Right. Well, and that is a perfect sort of a intro into what I was about to say, is that there is such a compartmentalized approach to a solution in this space, and the people that are making the solutions have completely different ideologies about what works and what doesn't. And so, like, for example, as you're describing communal living, and I start thinking HCBS settings rules, I know this is really technical, but there's these rules that the federal government has put in place that says we can't have communal living because it creates too much isolation, because you're taking a cohort of people and you're moving them into one location, and it's not, a mixed group of populations. You know what I'm saying? And so, and obviously, whether that's right or...
think about nursing homes then, because that's exactly what they are.
Exactly, right? So it's, but on the same token, do you think that multi-generational families may be somewhat of the answer in terms of solving some of these long-term care challenges?
I think so, it is, but I think what other communities are thinking about is other ways to bring communities together. And we have a few things like the NORCs, the nationally recurring retirement communities, or the village-to-village model, where neighbors are helping out neighbors, maybe trading tasks or trading, doing some time banking, those kinds of things. But I think a lot of it is just intentionally placing people of different generations in housing areas where they can naturally interact, where they can support each other. Because of the aging of our society, and because of the mobility of children and grandchildren, leaving all that to blood relatives just doesn't work. And I think we need to leverage our community consciousness to really make this happen. And I know that may sound a bit more communal than the American society traditionally is, but the truth is that we are facing that. We are facing a need to shift our focus from I want to live in my big private house with a deck on the back so I don't have to see anybody, to I need to be in more of an integrated community, and I need to look out more for the people around me because they will look out for me when I develop some difficulty. And it's going to be a big shift in the American mindset. But I think that aging is going to force this paradigm on us, and hopefully it will do so in a good way. We will become, right now we're a very fractious society, let's face it. And we're divisive from the government on down. Mm-hmm. Maybe this is a way to help heal some of those rifts, to really help us get to know our neighbors and to understand how we can all help each other. And also that demarginalizes elders and doesn't just see them as recipients of services, which creates excess disability, but also helps them to stay engaged in meaningful work. They could do, after school child minding for a working parent, or they can do volunteer work in the community. They don't need to sit at home and wait for a meal or a medicine to be delivered and say, I'm retired, I no longer have anything to give back. So it really changes the paradigm about what can older people give as well as receive, and what is our responsibility to everybody else in our community to keep it thriving and resilient.
So as we're talking about these paradigm shifts, as we're talking about these culture changes, what are some of the most significant changes that you've seen in recent years, and specifically how have these changes impacted dementia care?
Well, I think, Leif, if we can just start by talking about long-term care or nursing homes, the biggest changes I think have come from those major movements. The first one I heard of was the Eden Alternative, which was founded by
Hmm.
Dr. Bill Thomas and his wife, Jude Thomas. The Pioneer Network, with a group of people like the Thomases and others who were doing informative or transformative things, formed shortly after that. And then Bill went on to also start up the Greenhouse Project, which is one of the premier models for long-term care that I've seen in this country. And what they've all done to try to link them together as best I can is they see that the hospital-based institutional model of long-term care is no place for anyone to live or grow or thrive. And that we
Right.
may focus on caring for the body, but we leave people spiritually and psychologically bereft in these types of environments, and we need to re-energize and re-engage people. And that was certainly my cue. So when it comes to dementia care, I took what I had learned from all my training in these models and said, okay, how can they said, okay, nursing homes can be different. How can we reimagine them? So why can't I think about dementia that way? Why do I just think it's about brain disease and decline and loss? Why can't I think, how can I reimagine the experience of dementia differently? And at that time, I was also meeting people who were living with dementia, who are the best stigma busters in the world, because you talk to people about their lives, how they feel, and you realize that it's a much bigger world than you ever imagined. And even I, who had
Right.
cared for people with dementia, am ashamed to say I wasn't paying enough attention to what they were teaching me in the early days. And when I learned from people who were more able, who were speaking at the WHO or giving lectures and conferences and writing books, I then began to look at everybody with dementia as a potential teacher who's instructing me about what they need to live well and what I can do to help us all to live better.
So what are those common misconceptions that you're talking about when you say dementia and dementia care? And more importantly, how can we better educate our communities to challenge these misconceptions?
One big misconception is that the person is somehow disappearing. And I know that when you have a long-term relationship with somebody and you see that relationship change, that's a lot of grief. That's a lot of loss.
Sure.
But the person is still very much there. The person is living with a cognitive disability. I think my greatest mentor, the late Dr. Richard Taylor, who lived with Alzheimer's, taught me first, before anybody else, to see dementia as a cognitive disability and to say, instead of saying, that it's a fatal disease, what can we do to accommodate this, to help people to engage with the world as best they can, instead of just asking people to conform to what we do or medicating them if they can't, which is pretty much what we do. And I likened it to ramps for people in wheelchairs. We don't ask people in wheelchairs to walk up 2 flights of stairs. We give them a ramp or an elevator.
Correct.
And so what are the cognitive ramps for people with dementia? Why is it, whether you're home or in a nursing home, that people with changing brains are asked to live according to our schedules and our rhythms and our view of the world? And then when they can't tolerate that, we just diagnose a behavior problem and medicate them with these dangerous pills. So that's a big one. And I know it sounds blasé to say to somebody who's struggling with a loved one, they're not fading away, they're there. But the truth is that we have to see the humanity that exists in that person. And I'd like to see people as fully formed adults who are living with a cognitive disease or disability, and realize that they are still fully formed adults. They just had the same problem that a person with a stroke or a person with diabetes would have, but different in a challenging sort of way. But at least it keeps us engaged in trying to find solutions and not just writing it off to it's just the dementia, basically.
You know what I think? And you were, as you were speaking, I was like, okay, yes, this is exactly how I look at it. I feel like people don't have the time, which in turn means they don't have the patience to be able to actually care properly, to be able to actually live with someone who has dementia, because it takes a lot of time. But we as a society, we have a finite amount of time, and we want a result right now. We want, if a problem comes up, we want to solve it immediately. That's how we've been trained our entire lives to do. And cognitive disabilities don't work that way. And I feel like a lot of the frustration comes from the fact that we just don't have enough time. When we train our staff, we're not training our staff to spend, 24 hours a day, 30 days, over a course of a 30-day period to try to understand and get to know these individuals. Most of the time, it's 3-4 hours a day, 3 days a week, and that's it. And that's just not enough time either. So
Yeah.
I'm always curious to hear
barrier.
that perspective.
It's a huge barrier in both the formal care settings and at home too. In the case of the formal living settings, once again, that gets
Sure.
into system transformation because the system tends to focus on time and task instead of people.
Right.
And so you can educate somebody till you're blue in the face about taking time and connecting with people, sitting down and having them help you with a task and not just doing it to them. But then if they work in the system that says you got to get 8 people up in the next half hour because the breakfast
Right.
trays are arriving, then all that
Yes.
education goes out the window because the system overcomes all that. At home, to be fair, it is a superhuman job for anyone, regardless of your
Yes.
to be
Good
the nurse, the social worker, the cook, the caregiver,
The doctor.
the psychologist, and the
Right.
spouse or son or daughter or partner,
Right.
24/7. It is difficult, and some people do it pretty darn well, and other people, it takes a lot of skill, and some people just are presented with something that they are not ready to handle because they've never had to
Yeah.
deal with something like that before. It's a very challenging thing. And when we talk about finding, staff who have those skills, imagine just voicing that on a family member without any preparation or any knowledge
Right.
about what to do.
Yes.
It's a really tough thing. I did want to get back to another misunderstanding, though, which I think is the biggest one.
Please.
And the
Absolutely.
one that I spend most of my time yammering on about these days is that I do not believe in the paradigm that we call BPSD, the fact that people's words and actions are behavioral and psychological symptoms of dementia. This relegates people's expressions to brain disease, and it is really, in my mind, the slippery slope to medication or the slippery slope to reactive interventions that don't really help the root causes. And I believe that dementia does affect how you respond in a given situation, but the root causes of distress are deeper and almost always addressable. And so even though that has become universal terminology, I've been going around trying to set little fires and tell people to stop using this mindset, because as soon as you believe that the dementia is causing the person to act the way they are, then you stop trying to figure out what they really need. And you may say that you're going to try some non-pharmacologic approaches, but your default is always it's the dementia. You never put in the effort or the creativity that you need to find those solutions. And I have found that if you have the right environment, you can virtually always find solutions. You may not be able to provide them at that time because your nursing home or your spouse may not have the tools at that moment, but those needs can be identified, and in the right environment, they can be addressed. And I'm co-writing a book with two colleagues, Dr. Jennifer Carson, and who's a gerontologist at University of Nevada, Reno, and Pat Sprigg, who is the CEO of a wonderful retirement community in Chapel Hill called Carol Woods. And we were saying, if someone does not have major psychiatric illness outside of dementia,
Right.
can we think of anybody in our history who we think absolutely, and no matter what the setting, would have had to have an antipsychotic? And none of us could come up with a name. And so
Exactly.
even though there may be emergency situations or the caregivers may not be able to provide what is needed at that moment, the solutions are there if we look. And I think that the paradigm that says this is just a disease takes us away from doing the due diligence to find those. And we owe it to the people we care for to find those solutions.
Absolutely. And I'll give you a little bit of background. So I've been doing this for going on 12 years now. So this has been, aside from one other job, this has been my full-time job. Obviously, my wife and I own this business. And so we're all in when it comes to long-term care and the healthcare industry as a whole, right? And so when we started with I break the care process down into 3 steps. So step 1 is you live in your home independently and you receive intermittent care a few hours a day. Step 2 is you live in the community in a setting like a residential supported home where you have staff come in and you receive, between 18 and 24 hours of support. So much more. And then obviously step 3 is you have to be in a skilled facility and you need access to routine nursing care. So when we first started, we didn't really have much interaction with nursing homes because we were taking care of people who were just living in their own home, and we would come in for 6 to 8 hours and help them with their non-medical care needs. But then we decided to venture into the second step of the care process. And we were taking people out of the nursing facility and transitioning them back into community living, primarily, and just deinstitutionalizing them, essentially. Now, we've had plenty of success stories from people who have improved their overall quality of life, have received a high level of independence, and actually, instead of the typical version of declining health, so rapidly declining health in a nursing home, we've actually been able to improve their overall health outcomes. Now, not for everybody, but there's been some. There's a question in here, by the way.
Yeah. I love hearing what you're doing, because I think that shows what's possible. And I think we all think of things as a one-way street,
Right.
And dementia as a curve that goes, downward.
Yeah.
And the truth is that a lot of that is excess disability. It is not the illness itself.
Right.
And when you remove some of those barriers, people can grow.
Yeah. And I'll talk to you, that excess point is exactly what I'm trying to make. When we transition people with a cognitive disability, especially out of the nursing home, the list of medications that they have is 5 times as much as when they live in the community. For example, we may have 5 scheduled medications every day. They may have 25 in the nursing home. And these types of medications are they're narcotics, they're antipsychotics. And I honestly, some of the people, after they've lived in the community for, 6 months usually, they get acclimated to their environment, and they still suffer from a cognitive disability, but the medical history that they have that's written about them in the nursing home is vastly different than in the community. And so I guess the question is, how did we get here?
Yeah, I think I heard a statistic many years ago about the kind of people who live in nursing homes. If you take that kind of an older person, for every prescription drug they take, there's about a 10% risk of a significant side effect, and that's allergy. So if somebody's on 8 or 10 medications, you can almost guarantee that they are having either side effects from the pill or drug interactions between the pills.
Right.
And that, no matter where they live, that happens at home, it happens in the community. Part of it gets back to exactly what you're talking about, the mindset of time, not wanting to figure things out, not wanting to do things that take time, but for the quick fix. And for the past 30 or whatever years since we've allowed free market advertising, every TV show you watch, every magazine you open up has drug ads as the solution to your problem.
Right.
And this is the mindset we've created, is that, I remember seeing a patient back in private practice many years ago, and he needed to lower his cholesterol. He needed to stop smoking. He needed to stop drinking. He needed to lose a lot of weight. He needed exercise. And I remember him coming in one day and saying, Doc, someday they're going to have a pill, and I'm just going to be able to smoke and drink and eat what I want. And they're going to give me this pill, and it's going to go away. And I think that's kind of the fantasy that many people have, is that, there's a pill for your problem. The problem is that then you need pills for the other pills. A lot of people come to nursing homes from hospitals, and a lot of it happens there. And so, for instance, everybody that goes in the hospital gets a pill for stomach acid, because they know whatever's happening to you in the hospital is probably upsetting your stomach. So if you want to look at the purple pills and all those, virtually everybody who comes out of the hospital is on one of those purple pills, because that's just something that happens. Virtually everybody's on a pain pill. Virtually everybody's on some sort of bowel medications. Virtually everybody's on, and it does pile up like that. And also because we often have a fragmented medical system where there isn't necessarily a GP who is a point person, especially in the hospital where they often don't transfer care. You get a lot of different specialists each weighing in with their own drugs. And next thing you know, you got, a pile of drugs, and one doctor doesn't know what the other one is giving them. That's why geriatricians have what they call a brown bag procedure, where they ask patients to bring in every pill in their cabinet in a big brown bag so they can look at all of them and say, do you take this? Do you need this? How old is this pill? And really do one centralized look at what people are dealing with. Because because medications, I'm an internist, I prescribe medications that they can be a lifesaver, but they also have that other side if they are overused or used improperly. And that's my point with dementia beyond drugs is not that there's never a good drug to give people, but that we can't just focus on them when there are deeper needs. And whether it's improving people's diabetic control through exercise and diet instead of just piling on the pills, or whether it's not giving someone an antipsychotic for dementia, they're all kind of the same mindset of how do we approach our societal issues.
What is your go-to solution when somebody is suffering from dementia and it's progressed to a point to where they do have these frustrating episodes that we classify as behavior episodes, injury to yourself and others? What is your go-to to say? I mean, and I know it's not a one-size-fits-all type of answer, but something that people can actually try and use to see if maybe it would de-escalate the situation and prevent them from, being prescribed Halidol.
Yeah.
Something crazy like that.
I have something that works very well for me. Before I do that, let me just do my due diligence, because my friends who live with dementia would want me to do this. But they tend to not like the term suffering from dementia, because even though we all suffer from time to time, that kind of predisposes our attitude to that's what it's like to live with dementia. And so they like terms like living with dementia or living with a diagnosis.
Living with dementia.
Because
I'm learning all the time, by the way.
Yeah. And not saying things like, we've all used these words, and I'm constantly challenging my language, but I know that my friends would say, hey, don't let them say that,
Absolutely.
So I just point that out.
Thank you for correcting
what
me.
I've been doing. Yeah, sure. What I've been doing, and it was the focus of my second book that came out originally in 2014, was I started looking at a more proactive strength-based approach instead of just trying to correct what's wrong. And there was a white paper that some folks affiliated with the Eden Alternative came out with many years ago that looked at the needs of older adults in general. And they talked about well-being. And they came out with one framework for well-being where they described 7 domains of well-being that they felt were universal human needs, regardless of age, nationality, culture, whatever. And so for my second book, I decided to take that framework and apply it to the experience of people with dementia and say, okay, how do these domains look in a person living with dementia? How are they challenged by the disease? But also, even more importantly, how are they challenged by the care setting and the well-intentioned caregivers who might actually be eroding those aspects of well-being? So the model that they use, which I kind of reordered for my purposes, the 7 domains are identity, connectedness, security, autonomy, meaning, growth, and joy. And as I worked with that and wrote the book and discovered all these things I hadn't discovered when I wrote my first book, it came to me that there was a way to use that to sort of decode distress and find a different way to respond to it. And what I have found is if someone doesn't have an obvious cause, like you got a bladder infection, you need an antibiotic, then you're fine, those kinds of things. If someone has a more complex type of distress, particularly recurrent type, that you can't quite, nothing you do seems to work, I often find that the root is in those domains of well-being, that one or more of those aspects of well-being is being challenged in that person's life right now. If a person is resistant to someone who's trying to give personal care, like a shower, if they're yelling or resisting or fighting back, I almost always start with looking at security or autonomy. Any of us would fight back if we don't feel safe or don't feel in control.
It's a good point.
But the other important thing is it's not just about, de-escalation is important, and I have some things I teach about that. But really what I'm looking at is 7 glasses that are nearly empty because we've never been taught how to support well-being. We're taught how to give showers, and how to give medications and take blood pressure and prevent bed sores. We're never taught about how to give people autonomy or security or meaning in their lives. And you talked about purpose right up front. That's one of the 7 domains, meaning purpose. And so what my method does is it has people talk about the person's distress, their words, their actions, and then to look at the person through their eyes as best they can, talk to them if they can, and figure out how full those 7 glasses are. How much identity do I have right now? How much of a sense of connectedness or autonomy or security do I have? And what I've found, I've taught this technique to staff in a dozen countries on 5 continents, and really smart, caring people. And yet I've found that when they present a challenging case, they can look at these 7 glasses, and it's rare to have more than one that's 30% full. So I can stop people right there and say, everything you taught has left you with these 7 areas of human need that you've done nothing for. So are you shocked that people haven't gotten better, or that you're giving them drugs. But then the key is not just to react in the moment, but to start filling those glasses proactively. So if the emptiest glass is about autonomy, what are the ways you can give back choice and control to that person, not just when they're upset, but through every interaction of the day? Because it's not about curing dementia or just calming in the moment, which is what a lot of our interventions do. But it's actually about building that reserve and resilience so that when they're in a difficult situation, they won't be as likely to have a crisis or get distressed. And so it has worked incredibly well when nothing else helps.
Why aren't we teaching that to individuals like myself that run these organizations? Why are the people who are caring for hundreds of thousands of people, why aren't we being taught exactly what you're saying? Because it makes so much sense.
Yeah, well, it's, I always say there's two of the problems we have with education are not enough education and the wrong kind of education. And I won't say that there are many other good educational programs out there. I'm not saying I'm the only one that has something I think has some value, but there have been some opportunities. I actually was able to teach this in 10 different states, me and my colleagues from Eden. I have a 2-day course I developed for the Eden Alternative, and CMS, through their monetary penalty funds, was able to sponsor myself or my colleagues to teach this to nursing home staff and surveyors in 10 different states over the years from about 2012 to about 2017. So we taught it in the Carolinas, in Oklahoma, and Texas, and Colorado, a lot of different places like that.
What about...
So we've done that, and I do it whenever I can. Actually, there are some people in Arkansas who have taken this to another level, where my friend Dr. Angela Norman and her colleague Emily Snyder, they're nurse practitioners, but they have a consulting group. And they started with this well-being approach, and they started with small pilots about 7 years ago. And they have built it to the point now where they have a group of 92 care homes in Arkansas that are applying this well-being, both in care planning and in case conference discussions around distress. And before the pandemic started, they had cut their antipsychotics by half, and we're down to an average of 6.5% antipsychotics. That's an average across 92 nursing homes in Arkansas, which is 41% of all the nursing homes in Arkansas. And I won't say this is the only reason, but when you see that percentage, Arkansas went from 47th in the nation in antipsychotic prescribing, almost worst, to 11th in the nation in the last decade. And so they're doing well, and they also cut down their discharges to their psych units and hospitals by 75%. Amazing. And those numbers held steady during the pandemic. They did not go back up. So it does have a lot of promise if people can, but you need to embrace it and you need to reinforce it. And so I can teach it, but you need those champions that will bring it back again and again when another problem happens, to sit the staff down and say, okay, what do we learn about this? Let's go through this exercise.
It's really surreal because so much has changed since the pandemic. And prior to 2018, the state of Tennessee, it's where I'm from, we had a speaker come in and presented to a cohort of people that we were shifting in a person-centered approach in terms of the way that we have care provisions. Do you talk to a lot of systems, not just providers or network groups, but you actually go to the top of the pyramid and say, this is what you guys need to put in place for how people should provide services, and let it trickle down to the provider network? Because people like myself are at the very bottom of the totem pole in terms of, who gets to make decisions on behalf of the system as a whole.
I try to. It can be hard to get to some of those people or to get heard. Part of the problem is I'm a practitioner. I'm not a researcher. And so because this is really something that is kind of a de novo thing, and it's hard to get funding to do randomized controlled trials of well-being.
Good point.
A lot of people won't take something that's not published in journals. So that's been a hard thing, is to get people to embrace something that they can't see, in one of the major medical journals. But unfortunately, dementia is so medicalized that in order to study this, you have to abandon a lot of the research methodology that most dementia research is based on, because it rejects things like BPSD. And so you're really in a catch-22. I might mention that in 2012, 13 years ago, Tennessee was the first state that CMS paid us to do training in. Unfortunately, it was a new thing. We had several hundred people but still, only a small percentage of the homes of the potential staff that could have attended. We did it twice in Nashville, once out in in Tennessee, and once in Western Tennessee,
Right.
out I think in
20.
Memphis,
Yeah.
and you couldn't always get people there. You can offer a free seminar, but they have to pay people to travel to stay overnight in a hotel.
Yeah.
So there's all those systemic barriers too. But as far as
2012.
the higher groups of people, yeah,
Mhm.
that's how long it's been going on. I actually did the first pilots back in 2011 and early 2012 in individual homes in Ohio and Rhode
Amazing.
Island before I launched it. But yeah, the higher powers are tough. CMS was involved in those, and I know the ones we did in the Southeast, Region 4, Stephanie Davis, who was the head of CMS in Region 4, attended many of those. And she has been a great advocate, and she has talked a lot about this. I know that Vincent Davis, no relation, who was the head of the State Health Department in Tennessee when we did it in 2012, really was behind this, and he actually there were a lot of higher level provider, like some CEOs and administrators,
Sure.
and he actually gave them an assignment to report back to him if they attended this in 6 months, and let him know what they were doing to work on this and create an action. And so we try, but it's systems are hard to break into.
Well, and it may be time for you to come back, because I will say 2012 was 2 years into TennCare 2, which started in 2010. And there was a lot of change, and a lot of new providers were joining the network. So I think that it may be an opportunity for you to come back. So I'll put a bug in someone's ear. But I want to, I want to talk about your kind of like the international scope and the experiences that you've had throughout your career. You've had the opportunity to collaborate and work internationally on dementia care. Are there any daily approaches or practices from other countries that you believe we should adopt or learn from?
I think there are definitely some, and I don't think there's any one place that has it all. I think there's some things we do very well in the U.S. For instance, I talked about the greenhouse project. I think the greenhouse model is a wonderful small house model for caring for people in general. Most of the greenhouses are not segregated, so people with and without dementia may actually live together. And and I think that's great that they're able to do that. And so there are certainly some models like that. There are other models. I just was touring a woman from Sydney, Australia, named Tamara Krebs, who runs a small group homes called Group Homes Australia in the Sydney area for people with dementia. I've been to another great place called Dagmarsminde, which is north of Copenhagen, which has a wonderful small house for 10 people with dementia. And the Eden Alternative has active chapters in many continents. I'm going to be doing seminars in Denmark this fall. I've been to Denmark 5 or 6 times to do these Eden seminars. I think that in general, Northern Europe, Scandinavia, does relatively well with long-term care compared to others. They tend to use fewer antipsychotics. They were world leaders in getting rid of physical restraints many years ago. They tend to have smaller, more outdoor-oriented living. People are used to being outdoors. They don't mind a little bit of rain or snow, and smaller places. One thing that we really could do here, and I don't know, I don't know why COVID still hasn't made it happen yet, but nobody should, when they're 80 years old, should have to move into a place where they're put in a room with a stranger and shared room, and shared bathroom, and a shower down the hall. And one thing the greenhouse has shown is that you can actually improve people's lives by giving them a bit of space, a bit of privacy. And once again, that's partly cultural. There are some countries where communal living is maybe less abhorrent. I've been to some countries where there might be 6 people in a room, but I think that when you think about privacy, when you think about dignity, when you think about infection control, for example, private rooms are kind of a non-negotiable as far as I'm concerned. Then when you look at the larger structures, Scotland does something really well. And that is that I did some work with them several years ago, and their dementia care is dually funded between medical and social buckets, financial buckets. And so it's not just all about medical care. And they actually put a lot of money into the first year after diagnosis because they believe that an intensive year will help affect the trajectory of the illness. And so they give rehab, they give education, they give nutritional advice. They do all these things early on. And in a similar way, Alzheimer's Western Australia, who I've worked with quite a bit in Perth, has had a grant for over a decade where when someone's diagnosed with Alzheimer's in the community, they will go out and they will hook them up with a volunteer opportunity. So when everybody else says, you're sick, you can't do anything, they're saying, no, your community needs you. Stay engaged. You will live longer. You will live better. So you hear these little things, these pockets of great practice that are happening out there. Kiama, south of Sydney, I've been to, has a wonderful dementia-friendly village initiative, which is one of the best in the world. And so once again, and I hate to name too many names because I'm leaving out
not at all.
the great people. In addition, I work with Schlegel Villages up in Ontario, along with the Research Institute. And one thing that they've done in the last 2 years that's really amazing is that they opened up 20 private rooms that were empty in an assisted living building, and they offered to the hospitals who had a huge backlog of people with dementia who were hospitalized for whatever reason, got sedated, got restrained. Nobody would take them because they looked like serious behavior problems. And they said, we'll take 20 people you can't move into long-term care, and we will take them here. And they have a rich staffing. They have a really deinstitutionalized environment. They have very innovative dementia education. And they have been giving these people what I call, emotional rehab. These people were in the hospital, sedated and restrained for months or even years during the pandemic.
Terrible.
And they've come out and they're getting them back on their feet. They're not seeing any physical altercations. Right. They're not seeing sundowning. Interesting, because they work 12-hour shifts. And it shows me when you work 7 to 7, actually your activity around that afternoon change of shift is often triggering people. And they don't see it when they're calm because they're not going anywhere at 2 o'clock. So they're hanging out with the residents, talking to them. And they have, like you, they have graduated people to lower levels of care by getting them through that. People that no nursing home would take are all of a sudden going back to living in retirement homes or, places that where they never would have been imagined they could live before. So that's one particularly great thing they're doing up there that I would highlight.
So I got to ask, are you optimistic about the present situation of long-term care in the United States?
Not particularly. I mean, I sound very enthusiastic and positive, but I don't mean that in a negative way. I mean that in a way to say that the present system can no longer be tweaked. This is not the answer. There's two things. Number one, the present system has got to be dismantled and rebuilt from the ground up. It's not just up to nursing homes to get better. The regulations need to change. The reimbursement mechanisms need to change. The liability insurance environment needs to change. People's attitudes about aging and dementia need to change. And we really need to do. It's like that National Academy of Sciences report that came out last year about the state of long-term care. They said that there needs to be fundamental transformation of the system, and I would agree with that 100%. So that is one aspect, but also the other part we talked about the fact that long-term care itself is not the answer. We've got to start building community-based solutions. And the other thing you referred to when you talk about getting people back out, we got to break down the silos in elder care between community, assisted living. I was talking to Tamar Krebs from Sydney about this, and we were saying, why can't a person who's living in the community with dementia just come in to a nursing home for a few days respite so their partner can go on a break or something? Why do they have to be admitted to the nursing home and get a new doctor and have medication prescribed and then be discharged? And why can't we just have much more
capitalism?
Yeah, I guess so. And regulations, it's crazy regulations and liability, if we could make this more seamless and help people to have a much more integrative network of living, I think we would do a lot better. But once again, that's nothing you can do with a law. You have to break it all down. And it's time. It's time.
Yeah, and the siloing is, I mean, when I say capitalism, I mean I'm being glib, of course, but what I mean by that is we've turned what should really not be considered big business into big business, and so now we have all these people who aren't willing to work together. You would be astounded how many times I have tried to build a network of providers to say, let's collaborate and fix these problems. In our community of 100,000, and I'm going to go totally down the rabbit hole now. In our community of 100,000, so I hope you have some time.
Yeah.
We have we have 15 to 20 providers providing various services for people with intellectual disabilities or developmental disabilities, for people that are elderly and physically disabled. We have senior citizen centers. We have countless nursing homes. I mean, it's like our entire community is built around healthcare, right? And the crazy part is there's a lot of communities that are just like ours. We're micropolises. And what I find astounding is we have no communication between providers to solve these large sort of overarching problems about how we can improve our workforce, the quality of services that we provide. And when we do try to work together, and this is what's going to blow your mind, is we are told that it is a antitrust violation to be able to partner together for the benefit of the industry as a whole. And so when you were talking about changing the regulations around it, it really does make sense. We have built a system from whether it's the Nursing Home Act of the late 80s or it's some of the laws that have been passed that are being interpreted or misinterpreted, is probably a better way to put it, in our industry. We do have to dismantle the system and start over.
Yeah, the Nursing Home Act is now 36 years old, over 87. And 36 years, a lot has happened to our older population. A lot's happened to the kind of people who end up in nursing homes. We are way past having to take a serious look at this. And there are a couple barriers. There's one there. We're competing for limited resources. And so there's a lot of this unwillingness to work together. The best thing we had in Rochester, one of the homes I worked for was part of a consortium of 5 nursing homes, and they were competitors, but they got together to do things like buying supplies as a group so they could have better prices. So they did do some cooperation within that. But the antitrust thing is a big issue that we have to work around. The other barrier is between providers and the government, because the government has this idea that their surveyors are enforcers. They can't help you. They can't advise you or counsel you. All they can do is tell you if you're in compliance or not. And when you set which is kind of silly saying you can't be objective because school teachers do it every day, So when you set your expectations up as my job is narrowly defined as enforcement, then you come in as a fault finder, and it sets up this very adversarial relationship. And as a result, I think it creates a wall, and I would like to see that broken down so that we could work more collaboratively with the regulators to do these kinds of things, because I think that would also help move things forward. I think there's just a lot of fear. Change takes a certain amount of risk, and I think that when you feel like your head's on the chopping block all the time, you're not going to stick your neck out and try something new. It's very difficult to get a provider to step out of their comfort zone. As miserable as it may be, it's probably better to them than taking a risk on something they don't know.
We always like to end the show with a call to action. For our listeners who are currently facing the challenges of caring for a loved one with dementia, what advice or resources do you suggest to help them better navigate this journey?
Well, I would suggest if you're actually supporting someone living with dementia, first of all, is to get information. Find those educational programs that really help you find durable solutions. To read the books by people with dementia that help us to understand what it's like, how they experience the world. I think the biggest problem, whether you be a family member or even maybe more importantly with operators and politicians and architects, is a problem of empathy. I think we always talk about person-centered care, to use that term, what people need, but we too seldom think about what if it were me. Do I want to move into a room or into a nursing home where I'm put in a room with a stranger for the rest of my life? Do I want to have 30 different people in the course of a month taking my clothes off and giving me a shower or helping me to the toilet, as opposed to 4 or 5 who know me well? Because I think that we think somehow that's not going to apply to us. And I've lived long enough to know that most of the things I would want for myself, would have wanted for myself as a 30-year-old, have not changed, and they probably won't change in another 20 years. And I think that what we decide today, we're not talking about what we're doing for our elders. What we decide today is we're building our own future. And I think people need to look at it that way. What do I want for myself? Because what I decide today is the world I'm going to live in, because it takes that long for change to occur. And so we better, the Zen saying is, the best time to plant a tree was 20 years ago, but the second best time is today. And so I think that's what we have to do is really look to ourselves, look at our common humanity with people with dementia or other people that need these services, and say, we could be there tomorrow or next year. And what kind of world do we want to live in, and how can we create that?